Stop. Yeah.
So, good evening, everyone. On the eve of World Kidney Day, I invite you all to participate in surgical advances in kidney transplant. I myself, Dr. Bipin, from Department of Urology and Kidney Transplant, AIG Hospitals, and along with me, I have my good friend, Dr. Sunil Pandya.
Hello.
Who is Chief of Anesthesia and Critical Care at AIG Hospitals. So, we will start the presentations. So, I will take up the first presentation. And I will be speaking on retroperitoneoscopic donor nephrectomy. Donor surgery has evolved from open donor nephrectomy to mini incision donor nephrectomy, laparoscopic donor nephrectomy, to retroperitoneoscopic donor nephrectomy, and robotic assisted donor nephrectomy is still in infancy. So, as a donor surgeon, we all are stressed as we will be operating on a normal person rather than a patient. So, as the surgical techniques evolved, the first laparoscopic live donor nephrectomy was performed by Lloyd Ratner in 1995, and after that the whole world took it seriously and most of the people now do it, and open donor nephrectomy is performed rarely nowadays. So, I will be talking on retroperitoneoscopic donor nephrectomy because I feel this is the way the donor nephrectomy should be done, as in retroperitoneoscopic donor nephrectomy the intraperitoneal transgression is not there, and that minimizes any chance of injury to the bowel, and besides we have direct access to the hilum. So, that is the first structure we see in retroperitoneoscopic. So, what you can see is in the image is the head end of the patient, the donor. This is the dead lateral position, the camera port at the mid-axillary line, the posterior port at the renal angle, and the anterior port, that is 5 mm port, is around 5 centimeters anterior to the camera port and around 3 centimeters superior to the interior superior iliac spine. So, once the ports are placed, the surgery begins. And with the help of hook electrocautery and suction cannula, the gerotas are incised, the ureter is dissected, and then the cranial end of zerotas fascia is incised completely. Once this is done, the kidney is lifted off the vas along with the perineal fat, and this carbon dioxide helps in some form of dissection that enters into the loose areolar tissue and helps in dissection. Once the kidney is lifted off completely, you see the lumbar vein by the side of the renal artery, and this should be secured carefully. Then the aortorenal angle is dissected. Then the perineal fat is excised posteriorly. This excision helps in creating more space. Then the focus is shifted anteriorly and kidney is freed from the perirenal fat anteriorly. This dissection continues from the cranial to the caudal end. And kidney is freed anteriorly and medially. Then the focus is shifted to the upper pole and upper pole is dissected, and this dissection continues till we see the renal artery from the anterior aspect. So once the renal artery is seen, this area is dissected, the fibrofatty tissue is controlled with ligature, and here the adrenal vein comes, which will be controlled. Once the adrenal vein is controlled, the superior edge of the renal vein is dissected off. Additional fibrofatty tissues and lymphatic tissues at the otorenal angle are freed. And the anterior part of the renal vein is dissected. The lower pole of the kidney is freed. The gonadal vein is secured with ligature. And the ureter is clipped and cut. After this, retrieval incision will be given in the iliac fossa. The renal artery is doubly clipped and cut, followed by renal vein clipping. Then the renal vein is cut. And kidney is retrieved through the pre-placed incision. On the right side, most of the places they are doing open donor nephrectomies. Here we use a modified stapler. This technique was evolved by Dr. Jamal actually, in absence of endo-TA staplers, where we removed one side of staple line and used this GI stapler for controlling vein. Now endo-TA stapler is readily available. So for this we need little more dissection of inferior vena cava so that it can be tented, and most of the times we do get a cuff, although at times we may not get, and at times we get an incomplete cuff. This is what is desirable. You can see the inferior vena cava cuff in the right donor nephrectomy. Then we also performed retroperitoneoscopic donor nephrectomy in duplication of inferior vena cava cases, and we published our series of 4 cases. And then there's a lot of hesitation in doing retroperitoneoscopic donor nephrectomies, and so we studied this parameter in an initial 102 cases of my retro donors. I did a retrospective study, and we found that 35 cases is the number of cases required to learn the retro donor nephrectomies. And ultimately this paper won the prize at ISOT 15. So my emphasis is that retroperitoneoscopic donor nephrectomy is a versatile way of doing donor nephrectomy. Any kind of vascular anomaly, if it is there, or on the right side also, this is a very versatile technique to do a retroperitoneoscopic donor nephrectomy. So thank you so much for your patient hearing. Any questions I'd like to answer? So I now invite our second speaker, Dr. T.A. Kishore, who is a dynamic urologist and transplant surgeon from Aster Medicity, Kochi. He has been trained from University of Miami in robotics and oncology, and University of Minnesota in endourology. His area of interest is advanced robotic surgeries, robotic kidney transplant, and he is one of the pioneers in doing robotic kidney transplant in India. So, and he has many publications to his credit, and some of the landmark papers are there from his side, especially the transvaginal extraction in donor nephrectomies. And also for last 5 consecutive years he has won the Chandigarh Best Video award, and that needs a lot of applause actually. So over to you, Dr. Kishore.
Thank you. Can you hear me, Dr. Pepe?
Yes, I can hear you.
Okay. So you can see my slides also, no?
Yes.
Okay. So, thank first of all Dr. Bipin and the hospital for inviting me for sharing my experience over renal transplantation for the last 5 years. This is our hospital. It's near a river actually, Aster Medicity. So, whenever we contemplate doing robotic transplant, there are a few concerns that we have. That is, one is like injury to intraperitoneal organs, how to tackle complications like bleeding. Is there really an advantage, or if there is, how do you do post-transplant biopsy? What happens if bleeding happens into the peritoneal cavity, or what is going to be the effect of pneumo on the graft function? So my endeavor would be directed towards tackling how to tackle these complications and how to manage these issues. So what I do differently than what the pioneers do, Dr. Modi and Dr. Halawat. So I basically learned from them. I went and watched them, both of them, and then I started in 2015. So I performed the first transplant in 2015 in Aster, July, and I do a little bit different. I combine Dr. Halawat's and Dr. Modi's technique. I place 5 ports as usual, and in case in obese patients, I place 1 more port. And then this is the cardinal difference. I raise a flap, just like we do for the prostate, radical prostate, but I extend that flap all the way towards the right side, where the graft is going to be kept. So this flap will be raised and until we reach the posterior abdominal wall. Until this point, we use a 30 up camera, and from here we switch the camera down to 30 down. And now I reach the posterior abdominal wall, and you can see something called the triangle of doom, which is preferred by the hernia surgeons, where the vas and the gonadal vessel meet, and the iliac vessels come directly inside that triangle. So you separate the vas to one side and the gonadal vessels to the other side, and then you dissect the external iliac vessel. And the bowels will be set cranially at this point to make space for the kidney to be kept. And this is the peritoneal flap. So it's a long flap. The bowel is seen on the other side. So it's kind of extraperitonealized. And this is the bowel which is being swept posteriorly. So the bowels does not come into the field. And I do a minimal dissection of the lymphatics. I just separate, tease it away. I don't divide it generally unless patient is obese. We end up dividing that. And I dissect cranially all the way up to the crossing of the ureter. And I loop the vessels. Subsequently, I place a gel point at the Fannin steel. So that is combination of Dr. Modi and Dr. Halawat, where the gel point is used, but at the Fannin steel. And then I don't use any pot scissors. I just cut with the monopolar scissors itself. I make a venotomy and then suture. And I take one anterior layer, posterior layer, and then do an anterior layer so that you can suture towards you. And the suture length is also less required, and then tie it at a corner. So once the vein anastomosis is completed, the artery is done in a similar manner. Again, I use Dr. Halawat's sponge. And I do the anastomosis in the same fashion. First the anterior layer, then the posterior layer. And then singe it down and tight. And then remove the bulldogs. Once the clamps are removed, the kidney is allowed to perfuse in the same position, and then the kidney is tilted back to the right iliac fossa. And subsequently, we can either do the ureteric anastomosis in thin patients where through the Fannin steel. And here you can see all the urine is getting pulled underneath the flap, so it doesn't really seep into the peritoneal cavity. And then I routinely do a Doppler. After that, we do ureteric anastomosis. So nowadays I use a 5-0 PDS for the ureteric anastomosis. And once that is completed, I go ahead and close the flap and completely extraperitonealize the kidney. So using a V-lock, so you can see the flap is being closed. And after that, we can visualize the kidney through the gel point, the final position. So the kidney is not fixed anywhere. It's just lying in the extraperitoneal cavity, just as we do in open transplant. So this is the technique of total extraperitonealization of the kidney. So the advantages are when the post-operative bleeding is limited to the extraperitoneal space, the graft does not have any issue with torsion, and the bowel interference, if there is an open condition, is very less. Renal biopsy can be done, and migration of bulldog clamps or needles does not happen. And as ice, if is kept, it will avoid like seepage of urine and ice into the peritoneal cavity. So other cases of note I have done is that one is this transvaginal, where we have placed a kidney through the vagina, and then place a gel point through that. I believe Dr. Modi has a large series of this, and then the kidney is placed, and then similar fashion we anastomosed. And this is the final skull. This is the right-sided graft. So initially I was a little bit hesitant to do the right-sided non-nephrectomy, but it can be done quite well if you get a good cuff with the stapler. Nowadays, Sendotia stapler is back. And I make a small venotomy and I shift the ports a little bit lateral towards the right side while doing the right-sided non-nephrectomy. So the camera comes a little bit lateral than the usual. here I'm completing the vein, and then going ahead. And we have done all across the board all types of anastomosis, but commonly we do either we trouser it in the bench or we do a double barrel anastomosis. This is one of those kinds. This is the two arteries are there, so we are suturing the first artery, and then this is the second one. And the second anastomosis is being completed. So a common technique is either double barreling or trousering in the bench or end to side. So far I've done about 168 cases, 158 are live and 10 cadaveric, and hospital stay comes around 5 to 6 days. Blood loss is quite less unless you get an anastomotic lead. The bed preparation time is about 20 minutes, and the anastomotic time comes around somewhere between 30 to 37 minutes in general. There are cases where it can go up to 42, difficult cases. And draft positioning and all those other steps would take around 30 minutes, and the ureteric anastomosis around 20 minutes. So the console time would come around 110 minutes, and the total operative time somewhere between 150 to 180 minutes. We have done about 33 double vessels. Since this is a leaving related donor program, we don't have the choice. Actually, we're doing only single vessels. We have done a few right-sided. A dual transplant was done once. Vaginal insertion, 3 cases. And pediatric cases up from 9 to 16 years, I've done 10 cases. We have done re-transplant, that is a second kidney placement in about 10 cases. In one instance, we did a total extraperitoneal, but we couldn't pursue because we found it surgically challenging. We had 4 mortality. One was sepsis in a cadaveric donor on the 5th day, and a lot of unrelated mortality test. I had the first case went for arterial thrombosis, immediately we converted. And the second case of arterial thrombosis happened at 144th case, and that was a real shock for me because I thought we were all through the learning curve, but I believe the patient had some sort of hypercoagulability. It was a young patient, actually, teenage boy. And we had other 4 conversions apart from these 2. 4 all were like vascular spasm, and it all subsided by its own. The output started improving once we opened it. So that is one area we need to figure out when the bone vascular spasm can sometimes force us for conversion. And we did 2 re-exploration in the night due to bleeding. One was a surface bleeder, the other patient had a coagulopathy, which was undetected. And wound infection is quite rare. Ureteric leak, again, we had 2 cases. Again, both were done through open, it was not robotic, through the fan and steel. Then delayed clot function in only both the 2 cases who had the arterial thrombosis. And of note, we had 3 lymphocytes. That is one downside because we are total extraperitonealized. And 2 of them came quite recently in the last 25 cases. Till then, we had only 1 case. We had to figure out there's any technical reason for that. And these are some of our transplantations, like publications that double vessels and transvaginal and early experience. So I think from this technique we could address most of our concerns. There is hardly any worry for intraperitoneal organ injury, and we can tackle most of the complications, including bleeding. Post-transplant biopsy can be taken without fear. And if you are doing open or through the gel point, you can even avoid the pneumoperitoneal effect on graft function also. My current concerns is like as a transplant surgeon, we probably should place the organ in the final position and do, but we are not doing it. We are like flipping the kidney. And some of the areas where the bleeding happens, especially in the anterior aspect of the arterial anastomosis, can be quite challenging to tackle. So far I haven't had, but it could be a real challenge if it happens on the other side of the anastomosis. Thanks.
Excellent presentation, and I appreciate and applaud for all your efforts in robotic kidney transplant. I have few questions. One is you told in every case you go ahead and do a renal Doppler. So suppose the kidney looks pink and although you don't have a haptic feedback, but then it after doing so many cases, you'll have a feel that the kidney is turgid and urine is coming out. So what is the role of doing Doppler in every case?
Not one is no unless you routinely use the Doppler. No, once in a while if you use it, I mean we may not like really be proficient enough for that. That is one reason. So that another reason is that whenever we are like shady kidneys, whenever the kidney is not like turgid, then we go do Doppler. We don't know what exactly is normal. So if you make a routine, every case we make it a protocol kind of thing. We know which kidney is perfused well. In a way, we learn from the kidney which is pink and perfused also. And some of the spasms, we can directly visualize the renal artery. Some of the spasm conversions can be avoided. So, and the best would be using an ICG. If you have an ICG, I have an SI. If you have an XI, you can use an ICG. Then probably the Doppler will be pushed out. Yeah.
Right. And for your cases where the kidney is from the right side, so what difference it makes? Means once you flip the kidney after doing the transplant on the right side, it looks little scary once you flip it, especially when the vein is very short.
One, as I said, I'm very selective. I take longer right renal veins. So very short right renal vein I don't take. Even in open and robot, both ways. And the guiding actually makes our life easier because one of the reasons for complications of the right renal vein is that it cuts through, because the graft actually pulls it towards the right side. If you're keeping kidney on the right side, there is it kind of descends into that groove and then it tears the renal vein. But with the robotic, it doesn't happen. So we can place the kidney on the bladder and then suture it. And then once kidney is turgid, the vein is full, the chances of cutting through is less. So actually it makes the life easier, the robotic right side. Probably if you choose your case in the right way, I think it's fine. Even in a very obese patient, I have done a couple of these right-sided were in the very obese patients. That's fantastic.
Right. Thank you so much. Thank you so much, Dr. Kishore.
Can I quickly ask something, Dr. Kishore?
Sure, please.
Yeah, brilliant presentation, and honestly, you're doing great work in India with this robotic technique of transplantation. I mean, there are a few centers which have taken up robotic transplantation in the UK. It hasn't been, accepted very widely. Now, one of the main reasons, and I keep asking robotic surgeons, particularly here in UK, is that on our average patient's age on the waiting list is around 50 to 60, and they are quite comorbid patients. And we find that even with open, open transplantation, that at times you go in, the vessels otherwise look well, but you can't even pass the needle through because they are so atherosclerotic. Now, despite all the best techniques available, you cannot 100% be sure that how good the vessels are or how bad they are going to be and whether to deny transplantation to those patients. So, do you encounter such situations where, I know I've worked in India as well and I've done transplantation there. We have relatively young population with quite healthy vessels. But have you encountered a case where, you opened a vessel and then found that because of lack of tactile feedback, that the vessel is atherosclerotic and you can't now go back? And you have to commit to do the transplant. Has that happened, or is that?
Actually, if you do carefully inspect it, we can actually see through the atheromas. Actually, once you gain experience, if you really go and keep close to the arteries, you can see those atheromas actually very close to the magnification. That is one thing I've learned over my initial cases. And whenever we encounter an atherosclerotic person, we just do the same. We fix the plaque. We fix the plaque with the inside-out stitch and then go ahead. And it's not quite uncommon. And actually, in my place, probably maybe 30% of the cases are above 45 years, and many of them are diabetic. It's not an uncommon scenario in our place, and most of them have a live-related, a female donating it. So it's slightly more challenging. Because one thing I found out is difficult with robot is that arteriotomy is quite challenging because you tend to make a bigger arteriotomy and most often the donor renal artery will be small. So I struggled there a little bit, I would say, but it's perfectly doable with robotic technique. It's just that you do with the same.
Okay. Thank you.
Can I ask one question? Kishore, very nice presentation.
Sure.
What are the contraindications to doing robotic kidney transplant?
Currently, we don't have because I'm a low volume surgeon because I cannot let him say choose like the very thin patients I don't do like board like abdomen. Again, that comes maybe 1 in 20 in our place. That is one, and the rest all I do tend to do robotic, especially females, obese males, even some of the muscular males. I tend to do robotic, and only contraindication would be from the anesthesia side. If they say you cannot keep on Trendelenburg position or any other, and of late they haven't had. Initially, they used to reject 1 or 2 cases, but I mean practically you can do everything, provided no other contraindications for laparoscopy. Say for example, you have a frozen abdomen or multiple previous surgeries. No other contraindications for wherever laparoscopy is contraindicated in general. Per se, robotic does not have any contraindication. Maybe a third transplant, I don't know. Third graft and all might be difficult. I haven't done.
And your you've done left iliac fossa robotic transplants.
Yes, I've done about 10 of them, left side. I think it's again no issues I have faced. Again, I do sweep this sigmoid towards again cranially, and it works well. I mean, it's as easy as open actually. Probably easier than open a little.
Right.
Thank you so much, Dr. Kishore.
Sure.
We move to our next speaker, Dr. Sunil Pandya, who is Chief of Anesthesia and Critical Care at AIG Hospitals. He was the best outgoing student at Sri Chitra Institute. He is instructor of ATLS and ACLS, editor of World Anesthesia Clinics, has 17 publications and 15 chapters to his credit, and has given more than 300 talks as a national and international faculty. Over to you, Dr. Sunil.
Good evening all. Thank you, Dr. Bipage, for having me on this lovely symposium. Before I start, may I request Dr. Kishore to give my regards to Dr. Suresh Nair at Exeter Medicity, who is my teacher when I did my postdoc.
Sorry, Vipin, we can't hear Dr. Kishore. No, we can't hear you.
Am I audible now?
Yes, please. Yeah.
So, good evening all. At the outset, I'd like to thank Dr. Bipin for having me in this lovely symposium. And before I start, may I request Dr. Kishore to give my regards to Dr. Suresh Nair, who was my teacher when I did my postdoctorate at Chitra in 1996. So next 10 minutes I shall be talking on advances in anesthesia for renal transplantation. And as Dr. Kishore rightly said, as far as anesthesia and anesthesiology is concerned, very rarely we contraindicate any patient with either robotic or laparoscopic surgery. Any conflict of interest? So when we talk about anesthesia advances, yes, we start with pre-anesthetic check, where we risk stratify the patients, the donor as well as the recipients. The optimization is planned, and we subject the patient to a new regime. I shall be discussing about this a little later. And the current COVID pandemic, will be discussing a little bit of COVID-19 and KTP, the perioperative considerations, preoperative dialysis, advances in anesthetic pharmacotherapy and monitoring techniques, immunosuppressive regimes, the recovery and the enhanced recovery protocol in that we have established at AIG hospital. And yes, we indeed help optimizing graft function. Well, I don't have to, you are an expert, I'm a lone anesthesiologist in your field, but yes, 1954, Guild and Murray et al. Started that, did the first successful renal transplant in a twins. And unfortunately, 25% of all recipients suffered delayed graft function needing RRT. But with the advances in anesthesia, advances in immunosuppressive therapy, advanced refined surgical techniques, the delayed graft function and RRT is now very, very less. But yes, despite advances, the cardiovascular complications occur in 10% of transplants in post-operative period with significant morbidity and mortality, and this is where the role of anesthesiologist comes and the role of optimization, preoperative optimization happens. And other comorbidities and occult infections and hospital-acquired infections, which is one of the notorious things in immunocompromised patients, have to be taken care of, which adds to the morbidity and mortality. So when it comes to pre-anesthetic assessment, the advances, yes, nothing much has happened in this area. But as an anesthesiologist, we also need to know why the patient has developed end-stage kidney disease. And yes, we start with history and physical examination, diagnostic workup, routine diagnostic workup, which is done by the nephro team, and preoperative optimization and the new regime. So generally, the end-stage kidney disease, as we all know, is defined when the eGFR reduces to less than 20 ml, and it's a irreversible cause of kidney damage, and the patient does not have any recovery of the nephron functions. And we also need to know patients who have autosomal polycystic kidney disease, because these patients may have occurred infections in the kidney, and these patients sometimes may require nephrectomy prior to transplantation. Generally, preemptive transplantation is one thing which is preferred, because we know that graft survival is better in these cases. But patients who have nephrotic syndrome with an etiology of end-stage kidney disease, in this patient, they are better off with preoperative dialysis, because we know that nephrotic syndromes are hypercoagulable state, and the graft function is better with preoperative dialysis. And maintenance dialysis, hemodialysis is preferred compared to peritoneal dialysis, because for some reason the incidence of allogenic graft thrombosis is quite high in peritoneal dialysis patient. So when we discuss about the comorbidity workup preoperatively, rather than subjecting the patient to a blanket preoperative surgery profile in transplant recipient or a donor, we at our hospital have tailored preoperative workup, which is efficient and cost effective. Basically at PSC we decide what the patient needs and what the patient may not need, because rather than, there are some hospitals where routine coronary angiography is done for all recipients. Yes, that is not needed. So effective and cost effective preoperative workup can happen when the patient comes to us in the preoperative period. And generally obese patients, we all know that if they get a small kidney from a small donor or a young patient, they may have insufficient nephrons and they may have a delayed graft function. As far as cardiovascular status is concerned, 25% of renal transplant patients, recipient patients, they have underlying cardiovascular risk factors, and the clinical 6-minute walk test with pulse oximetry is a very standard test, and more or less you can rule out major comorbidities. Other thing which as an anesthesiologist we do is the volume overloaded patient. We all know that renal transplant recipient is a patient with chronic hypertensive, reduced diastolic compliance, concentric LVH. So left atrial dilatation is a very significant marker of volume overload. And whenever there is a diastolic dysfunction, the left atrium dilatation occurs, and this is a volume overloaded patient, and they benefit with preoperative dialysis. Especially there is a good marker in preemptive dialysis patient. Presence of edema post dialysis when the patient is dry, again indicates subacute onset of congestive heart failure, and we need to investigate this patient. It could be either uremic cardiomyopathy or a cardiogenic cause. Non-invasive testing, as I said, is restricted, but if they have significant lesions, then better the patient is subjected to coronary revascularization before taking up for surgery. We need to look for other causes like peripheral vascular diseases, diabetes mellitus, central nervous CNS evaluation, especially if the patient has underlying adult polycystic kidney disease, then cerebral aneurysms are quite common, and these patients may need sometimes MR angiography before surgery to risk stratify. And if the aneurysm size is more than 6 to 7 millimeters, then they need clipping before surgery. Pulmonary status generally is quite insignificant, but some patients who are oxygen dependent, acute cor pulmonary or FEV1 is less than 25%, they are relative contraindications for transplant recipient. Thrombophilias and connectivity disorders, again thrombotic microangiopathies and graft thrombosis is very common, so we need to keep this in mind. Active and occult infection also have to be taken care of. I was talking about the new regime. The new concept is nothing but preoperative nutritional approach, endurance building up and allaying anxiety, the fundamentals before surgery, because if you optimize the patient on these lines, generally we can subject them to ERAS and have a faster recovery, shorter length of stay, less than 5 days or probably 5 to 6 days maximum, and early recovery and enhanced patient satisfaction. So generally we do function status evaluation where we include preoperative optimization of medical condition, titrating medications, correction of potassium, and dialyzing the patient not 24 hours within 24 hours, but generally 24 hours before transplantation is planned. Nutrient status improvement has to occur because most of these patients are nutrition depleted, they are micronutrient deficient, and sometimes asthenic patients, myopathic patients, they have delayed recovery and slow recovery. Endurance is nothing but targeting physiotherapy and limb physiotherapy so that they recover faster and they mobilize the patient faster post-operatively. Psychosocial assessment, counseling, non-compliance issues are important before we subject them for recipient, because compliance to immunosuppressive regimen is very, very important, and patients are non-compliant preoperatively, they need repeat sessions of counseling, and that's where the new regime also helps in these things. So once we subject the patient to a new regime, again reassess the patient. Generally, in our hospital, we routinely perform ultrasound of the neck because at least I would say about 5 to 7% of patients we find jugular thrombosis, and sometimes we have pan vessel thrombosis like subclavians, femoral and jugular thrombosis, especially hypercoagulable patients or sometimes with chronic neck catheters. So we put a central line, and this is very important for us to rule out thrombosis in the jugular vein. And being COVID-19 pandemic, RT-PCR done within 48 hours is mandatory, at least in our hospital, both the donor and recipient. And once they are admitted, we keep them in the bubble so that they don't get infected from other patients. On the day of surgery, we do this parameters routinely, which is a standard protocol. Pre-medication, acid aspiration prophylaxis, and generally we skip or review long-acting antihypertensives, because skipping the antihypertensives, especially ARBs and ACE inhibitors, are very important because sometimes they can cause post-induction profound hypertension, refractory hypertension. So we skip long-acting antihypertensives a day prior to surgery. Perioperative issues in donor, yes, age, BMI, and major comorbidities to be ruled out. A good pain management and ERAS is mandatory. So as I said, in recipient, we don't dialyze day prior, but we dialyze 24 hours before surgery, because if you dialyze day prior to surgery, some of the delayed graft function is quite common, and generally we do 24 hours before surgery. It's a heparin-free dialysis, and we use biocompatible membrane dialysis preferred, because if you use incompatible activates, it activates the complement system, and sometimes you see delayed graft function. So Q-profen dialysis are generally avoided in patients who are subjected for transplant. The target weight, we don't keep the patient dry before surgery. We generally keep the patient 1 to 2 liters positive, little greater than dry weight, so that the hypovolemia and incidence of hypotension can be minimized in the perioperative period. Potassium, targeted potassium should be less than 5, and generally more than 5.4, we postpone the case, and these are patients subjected to dialysis again. Preemptive non-dialysis patients, generally, as I said, if the potassium is high, if the patient is volume overloaded, we dialyze them. And as I said earlier, nephrotic syndromes, also RRT improves the graft outcomes and reduces perioperative thrombotic risk. Peritoneal dialysis, as I said earlier, the graft thrombosis is high. COVID-19 positive patients, what are the current considerations in the perioperative period? Yes, if they develop COVID-19 in the perioperative period, these patients, they have a very high risk of mortality and significant morbidity, long hospital stay. Importantly, if they develop preoperatively, it is detected, they lose an opportunity if they are on the cadaveric list and you have a kidney available. So these are all double jeopardy, and you need to be very, very careful. Transplantation is considered once the patient is completely recovered. Asymptomatic carriers who are positive, generally we wait for 4 weeks, and the COVID markers have to be reviewed. If they are all normal, they can take up the patient for surgery. Post-COVID-19 RT-PCR might remain positive to 70 days. So generally, post-COVID, after 2 weeks, if you do RT-PCR, if it is negative, fine. If it is positive, you don't have to worry about it, because even the dead virus comes positive in the RT-PCR test. As I said earlier, donor and recipient should be nursed in bubbles. As far as anesthetic goes in donors is concerned, we follow ERAS principle, short NPO period, solids NPO first for 6 hours, and for clear liquids 2 hours, patient can be on glycemic clear liquids, and ensure that patient has adequate hydration, at least 100 ml per kg per hour overnight. Surgical safety checklist, antibiotic prophylaxis, generally we use cefazolin 2 grams at induction. Lung protective ventilation strategy, avoidance of nephrotoxic medications, hemodynamic stability is ensured. Generally, propofol sometimes can cause profound hypotension, especially in the patient hypovolemic. So, hydration, overnight hydration helps in minimizing hemodynamic perturbations. Perfusion pressures are maintained, and standard non-invasive monitoring is the technique of choice. Generally, intra-abdominal pressures are optimal. Generally, most of the surgeons, our surgeons, they put at 15, and then at the introduction of trocars, subsequently we reduce it to 12. But importantly, you have to remember that hydration is mandatory. We give 10 to 20 ml of fluid crystalloid per kg per hour. intraoperatively, and targeted urine output should be at least 100 ml per hour so that renal perfusion is maintained. If the patient has hypotension, ephedrine and phenylephrine, small boluses can be given, but avoid multiple boluses because the half-life of ephedrine is almost about 2.5 to 3 hours. Subsequent doses. Mannitol is given before the warm ischemia begins. Multimodal analgesia and is used. Epidural can be inserted if the patient undergoes open nephrectomy, which is very rare now. Most of the patients we do laparoscopy in our center, and recovery is on reversal on table and transfer the patient to SDO. We have dedicated OT for laparoscopic surgery in our hospital. As far as goals of anesthetic goals in recipient is concerned, yes, immunosuppressive therapy has to be advised, is given as advised by the nephro team. Generally, ATG or in addition, methylprednisolone is given before the clamp release, and we maintain stable hemodynamics and organ perfusion pressures. Avoidance of hypertension, hypovolemia is mandatory. It's at some so we avoid giving antihypertensives 1 day prior before surgery. So whatever the cause of hypertension can be minimized. Biphasic hydration regime is what we follow. There is pre-graft and post-graft. Generally, we give about 5 ml per kg and subsequently 10 ml per kg per hour. So, almost about 30 to 35 ml per kg per hour crystalloid is administered intraoperatively. Targeted monitoring, the standard monitoring which we all do, ECG, pulse oximetry, carbon dioxide monitoring, temperature, invasive blood pressure. Invasive blood pressure is mandatory. CVP, blood gases and glucose. And advanced monitoring, especially if the patient's cardiac comorbidity, flow track, transcendental echocardiography, BIS and neuromuscular blocking agent. And of course, the ventilatory graphics, which is routine. We have a slave monitor in our theater so that the surgeon also keeps monitoring the hemodynamics. And this is just the dashboard of our monitor. Generally, we avoid low flow anesthesia in recipient as well as donor because we use sevoflurane, we don't want any sort of compound A activity which is a theoretical possibility, but generally we maintain the flows of more than 2 liters gas flows and warming devices, both the active body warmer as well as the fluid warmer to keep the patient warm. As I said, patient with comorbidities, we use transcendental echocardiography intraoperatively and flow track devices so that we can titrate the fluid appropriately and hypotension can be minimized. And these are the hemodynamic targets which may not be of any interest to you, but generally, as I said, we maintain MAP of 80 to 90 before graft, and once the graft is inserted, 90 to 100 is what our MAP is maintained. And IV fluid 30 to 50 ml per kg per hour, we give generally crystalloids. We restrict the use of normal saline to less than 2 liters to maximum 2.5 liters because we know that normal saline can cause hyperthermic metabolic acidosis, and importantly, this metabolic acidosis can cause hydrogen ion extracellular shifts and can cause hyperkalemia. So, excessive usage of normal saline is restricted. Balanced salt solution like praseolinate A or cabalate are preferred, and of course, ringwell lactate also can be is the fluid of choice. We don't give colloids, even albumin, starch is not given. Transfusion triggers, yes, we know this patient are chronically anemic. We have a high threshold for giving perioperative transfusions. Generally, we don't give till the hemoglobin falls to less than 6.5. If the patient has serious cardiovascular comorbidities, then 8 grams is the trigger, but we also go by clinical parameters. There are certain things which we need to know intraoperatively and perioperative postoperative troubleshooting. Hypotension is one of the commonest thing that happens post graft in anastomosis or in the postoperative period, but important cause is hypovolemia, and volume expansion is the key. Prevent and avoid hypotension. And other cause of hypotension in the postoperative period like graft thrombosis, vasospasm, urinary kink, and all those things have to be ruled out by Doppler and other methodology. If the patient has refractory cause, then cardiovascular cause, then TE or transthoracic echo postoperative period, they help us and we can do appropriate coronary intervention. Very, very rare if you maintain good stable hemodynamics intraoperatively. Small bolus of ephedrine, phenylephrine can be given. Dopamine infusion also can be given, but generally we avoid strong alpha agonist like noradrenaline because we know that it can cause reduced blood flow to the graft. Furosemide can be used depending on the advice of urologist, but low dose dopamine is contraindicated because it can reduce the perfusion of graft. Epidural generally we don't use, but sometimes if the patient has low threshold of pain, we use neuraxial analgesia and hemodynamics is stable, we give epidural analgesia post-operatively, and multimodal analgesia is what we advocate and we follow. Generally PCA, patient control analgesia with fentanyl, paravertebral block, corticosteroid lumborum block or tab blocks are given for post-operative pain relief. We don't give pethidine, we don't give morphine, because we know the metabolites of pethidine and morphine, they act for longer time and they are basically renal excreted, and we don't want to give anything that are nephrotoxic. Extubation is generally 99% of the time we do it on table, but literature, we have not ventilated any patient post-operatively so far, but as per the literature, 2.1% of patients, recipient patients, they require post-operative ventilation. Prevention of hospital-acquired infections is the crux in our hospital, and whatever you need to do, you need to prevent it. Fortunately, the CLAPSIs, COTIs, SSIs, and they all are very late. And we have a very dedicated ICU. You can see enough bed space between the patient, and importantly, the principle of ERAS is followed universally in our hospital, enhanced recovery after surgery, and there are a lot of papers. This was a paper that was published in 2019, basically short NPO period before surgery and maintenance of weight and the blood pressure. Generally, we don't drive them before surgery and start spirometric exercises. Patients are subjected to new regime. Perioperative period, yes, anti-DVT prophylaxis, prophylactic antibiotic, intraoperative basically tab blocks, and then fentanyl PCA, basically goal directed therapy, as I said, and early institution of oral fluids after surgery. Generally, we start NPO period is very short, between 4 to 6 hours. Once the patient has regained upper airway reflexes, cough reflexes, you can start clear liquids. And early mobilization, early ambulation is the key, so that the patient satisfaction is superior. So with this, I conclude my talk. Any questions I can take. Thank you very much.
Thank you, Dr. Sunil. One question I have, all those patients who are very high risk for giving general anesthesia, what is the role of regional anesthesia in kidney transplant?
In fact, we have done, actually I remember about a handful of cases, about 8 to 9 cases solely under epidural analgesia, with patients who are poor pulmonary compliance, pulmonary status. The only disadvantage with renal anesthesia is vasodilatation and hypotension. So if you can give good volume preload to these patients and good stable titrated epidurals, especially catheter congruent epidural analgesia, it can still be given, and it's not an absolute contraindication. The only thing is the contraindications for epidurals like heparin dialysis and thrombocytopenia and other things have to be taken care of, so that we don't have any other issues.
Thank you so much.
So, Doctor, let me just ask you one thing.
Yes, sir.
In Manchester here, we routinely use rectus cheek blocks.
Yeah.
For the donors as well as the recipients at the end, and then the patients go on, PCA, which in our experience has worked very well. So that is, and we are about to publish, the data on all these patients, and the results are very satisfactory. One interesting fact that came out of your practice is, giving dialysis to patients who come in for preemptive transplant.
Yeah.
Now we have 40% of our patients undergoing preemptive transplantation, and we never do that. So, how many sessions of dialysis do you give them before?
One or two maximum, because these patients, if they have late atrial dilatation and diastolic compliance or diastolic heart failure, or if the patient has, even preemptive patient who has hyperkalemia, because sometimes they may be diuresing well, but they have hyperkalemia, and these patients are subjected to 1 or 2 sessions of dialysis before. Otherwise, more or less, we don't dialyze them.
So routinely to all the patients preemptively, or just patients with
only preemptive dialysis, preemptive transplantation, we don't do dialysis. Only patients who are volume overloaded, and that too, just ultrafiltration is done, not the conventional hemodialysis. And if the patient has hyperkalemia, which is not amenable for medical management, like salbutamol nebulization or glucose insulin infusion, and the potassium still remains high, then a session of RRT is planned.
That's very interesting.
Yeah.
So thank you so much, sir.
Thank you, sir.
And we move to our next session, and I invite Dr. Syed Jamal Rizvi, who is Professor of Urology and transplantation at Institute of Kidney Disease Research Center, Ahmedabad. He has extensively worked in kidney transplant, and he is one of few surgeons in the country who does pancreas transplant. His area of interest is kidney transplant, pancreatic transplant, reconstructive laparoscopic surgery, and robotic surgery. He has more than 30 publications to his credit and many book chapters. He has been invited faculty at various national and international forums. Over to you, Dr. Jamal.
I'd like to thank my good friend Bipin for inviting me to this, and also it's an honor to be involved in a seminar with AIG, which is certainly an institute of excellence in the country. Now, so now I'm going to be talking, giving an introductory talk about pancreas transplant, which is something that we have recently, ventured into, and I think is a field of transplantation which needs to develop in our country in the coming years, and I believe that it can be done. Now, when this is advice that's given to young residents in surgery. First is eat when you can, because you're always going to be hungry. The second is sleep when you can. And the third golden piece of advice is don't touch the pancreas, because we all know as general surgery residents that the pancreas means trouble. Well, this reputation is not entirely undeserved, but I'm going to talk about why we have good reasons to do this. Now, the pancreas is looked upon as a difficult organ to transplant, and rightly so. It has the highest rate of non-immunological graft loss of any solid organ transplant. It's fairly unforgiving to errors. The reasons for this are fairly well known. There's a tendency to thrombosis because of swelling post-operatively and a sluggish blood flow, which I'll talk more about later. The pancreas secretes digestive enzymes, which can be cause a lot of damage when they're secreted into the abdominal cavity, and the anatomy is fairly complex, more so than kidney or possibly in the liver. However, sound surgical decision-making and technique can minimize these complications, and we have an excellent person to talk about this in the next presentation. Now, the incidence of type 1 diabetes in the country is about 10 per lakh of population. We all know the frequent complications, of which end-stage renal disease is the most damaging. Others are neuropathy, retinopathy, and vasculopathy. In fact, we've done pancreas transplants in a 30-year-old who's been post-CABG. A few centers at the moment offer deceased donor pancreas transplant, the most notable of which at the moment are PGI Chandigarh and Apollo Chennai. Now, the rationale for pancreas transplant is this, that it is the only proven method for long-term normoglycemia and type 1 diabetics. Islet cell transplants are gaining ground in the West, but they're expensive and the effect is often transient. There is a dramatic improvement to the quality of life, so the life enhancing, and life is also extended, as we'll see. It may slow or even reverse certain diabetic complications. However, these benefits have to be balanced against the complication rate. Now, this graph very dramatically illustrates the advantages of a pancreas. This is the survival of type 1 diabetics on dialysis. You can see that by 5 years, about 70% of them will be dead on dialysis alone. The results are better when you receive a deceased donor kidneys and even better with a living donor kidney. But you can see when they receive an SPK, pancreas and kidney transplant, the survival is superior, and this survival really increases as years go by. But by 15 years, there's a dramatic improvement over all the other modalities. There are 3 common types of pancreas transplant that are done for type 1 diabetics with renal failure. The first one is a simultaneous pancreas kidney transplant, which is about 80% worldwide. Typically, the recipient gets a pancreas and a kidney from the same donor. The advantages are that all the transplants are done in one operation. Immunologically, the organs come from the same donor, so it's not complex. Rejection can easily be detected because creatinine serves as a surrogate marker, and outcomes are better compared to the other 2. Pancreas after kidney transplant typically is when a pancreas is given to a person who has already received a kidney. This possibly would be the most feasible thing in the Indian scenario because unlike in the West, we have a driven program. So if you had a type 1 diabetic who came to you with a living kidney donor, the best thing to do would be to put in the living donor kidney, so that the person is off dialysis, and then wait and put a pancreas in when a deceased donor is available. And more rarely done is a pancreas transplant alone, which is in type 1 diabetics without renal failure, who have problems like hypoglycemia, unawareness, very poor glycemic control, and complications of diabetes, such as frequent diabetic ketoacidosis. Now the results, although historically they've been not so good, in the last decade or so they've improved. UNOS data shows that there's more than 95% patient survival in all categories. 1-year graft survival should be above 85 and really above 90% for SPK, and in the 70s and 80s for the other two types. 3-year graft survival should be about 2/3 in all categories, and rejection occurs. It's more common in pancreas transplant alone than in the other two. When it comes to the deceased donor, we have to be fairly choosy compared to the expanded criteria donors we can take for liver and kidney. Age should be less than 40 or 50 in some instances, although countries like the UK are actually pushing these boundaries and going older and older. The donor should be non-obese, should be stable and not on many inotropes. It can be brain dead or non-heart beating, although non-heart beating is less commonly practiced. And there should be every effort to keep the cold ischemia time below 12 hours. You're going to hear about this in detail in the next talk, but briefly, the retrieval is part of multi-organ retrieval. The pancreas is retrieved with a C-loop of duodenum. Staplers are used to divide the bowel above and below the duodenum. And a wide raft of common external and internal iliac arteries is retrieved and used to revascularize the superior mesenteric artery and the splenic artery. The anastomosis is usually done with the common iliac vessels in the recipient, and exocrine drainage may be of the C-loop of the duodenum may either be enteric into the small bowel of the recipient, which is more common, or into the bladder, which is easier to do but more morbid in the long run. This is just to give you an idea of the allograft being prepared. This is the pancreas, this is the C-loop of the duodenum, and this is the wide graft of the iliac vessels, which is being anastomosed to the splenic artery and the superior mesenteric artery of the graft. Now, the management is similar to other solid organ transplant. The specific things here are that there's a concern about the insulin surge from preformed insulin. So before opening the clamps, the recipient should be on an infusion of 50% dextrose, which can be neutralized with an insulin infusion to maintain a blood sugar of about less than 150. Anticoagulation is an important part. The pancreas allografts are prone to venous thrombosis. This is because the pancreas does not actually have its own blood supply. It parasitizes blood vessels of the SMA and the splenic artery. There's a low flow and high capacitance flow in the venous system, and this leads to a sluggish flow, which is prone to thrombosis. Post-operatively, there's usually a lot of swelling, which further compresses the venous system, and technical issues can lead to thrombosis. Therefore, many centers resort to aggressive anticoagulation. This can reduce thrombosis. However, the flip side of it is that it can lead to bleeding. So what we follow is to start the patient on aspirin pre-induction, treat with low molecular weight heparin. We used to give unfractionated heparin, but we found this led to a lot of bleeding complications, and also dextran to reduce platelet aggregation. After discharge, the patient is on self-injection of low molecular weight heparin for a month and on lifelong aspirin. Immunosuppression is similar to kidney transplant. We induce with rabbit ATG and maintain with tacrolimus, MMF, and prednisolone. Some centers practice steroid reduction, but early in our series, we have not done that. Now, complications are always of concern. Bleeding is a very common cause, although it's not a common cause of graft failure. It can be minimized by meticulous surgical technique. If this coagulopathy should be corrected, and as I've already said, this coagulopathy may be iatrogenic because of over-enthusiastic anticoagulation. And it's advisable to evacuate the clots because the clots can cause consumption coagulopathy and nidus for further infection. Thrombosis I've also talked about, and it can be made worse by suboptimal donors, high flush volumes, HTK solution versus EU is another risk factor in some publications. A prolonged cold ischemia time predisposes to thrombosis, suboptimal surgery, and rejection. So if it's suspected, we monitor the graft with frequent postoperative Dopplers, and if you suspect a thrombosis, then an early angiography should be done. Partial thrombin may respond to increased anticoagulation. However, it often results in necessity to remove the allograft. Graft pancreatitis occurs. Physiological pancreatitis occurs in every case with asymptomatic elevations of serum amylase and lipase. However, graft pancreatitis can be severe and may really lead to the need to do a transplantectomy. And sepsis and leaks are not uncommon. Deep wound infections can occur in the first month. They may be due to necrotic fat on the surface of the allograft, and they can often be managed with laparotomies and washouts, sometimes necrosectomies, but can be associated with graft loss and mortality. And a devastating complication could be an anastomotic leak, especially when there's a bowel-to-bowel anastomosis. Re-laparotomy can salvage the situation, or sometimes transplantectomy will be required. So just briefly, I'd like to talk about our experience. We're still fairly fledgling in this game, but this is something that we think we'd like to pursue. We've been having a busy deceased donor transplant since 2000. We do about 60 donations a year, out of which we do about 100 kidney and 50 to 60 liver transplants. So because we felt that we were wasting an organ, I did a 2-month observership at the Oxford Transplant Center. And we were unsuccessful in the first 4 years with 2 failures, and we won the back foot after that. However, in 2017 we restarted, and then last 3 years we've done 8 pancreas and kidney transplants. 5 of them were SPKs, and 3 were pancreas after kidney. And I do have a strong feeling that pancreas after kidney will be the way to go in the future. The recipients, as you can see, were mostly young. Many of them had a very long duration of diabetes. They were all type 1s, represented by this low C-peptide level. We've also been fairly selective on our donors. They were all under the age of 30, almost all head injuries. And this is important because you don't want donors with comorbidities. Our donor ischemia time ranged between 7 and 14 hours, and it was actually bimodal, in that donors from our own city, we were able to do it in about 7 hours, but a lot of our donors came from other cities, many of them 4 and 5 hours away, and this increased the cold ischemia time. And operative time for our SPKs was about 7 hours, and for the pancreas alone, about 4 hours. We had a share of complications. We had 1 patient who required exploration for hemoperitoneum, 1 for abdominal sepsis, 1 GI bleed, which settled down with 7 units of blood transfusion, possibly from the bowel anastomosis, and 1 prolonged ileus, which required TPN. 2 patients have died in this series. 1 who died 2.5 years after transplant with a functioning graft due to pulmonary infective complications, and 1 who expired at 1 month due to intra-abdominal sepsis and multi-organ failure. Of the remaining 6, 2 grafts have been lost, 1 due to chronic thrombosis of the pancreas allograft at 6 months, but the kidney remains functioning, and 1 venous thrombosis on day 2, which required early explantation. So our patient survival has been 75%. The death-censored pancreas allograft survival is 66%, and the kidney allograft survival has been 100%. So the challenges that we faced, one is that we had limited expertise. Our mentors in the UK did help us remotely, but it's not the same as having trainers on hand. We had a small team, and this leads to fatigue and difficult decision making. It's always good to have a friend. Although Dr. Bipin, when he was with us, he was of great help. Counseling is very important, and this has led to a few patients to drop out. And we have small donor and recipient pools. And this has meant that at times we've had an organ available, but because of a donor pool, we didn't have a recipient. So we're actually actively trying to be in touch with organizations of type 1 diabetics and recruit more and more patients for pancreas transplant. So the lessons we learned are that donor selection is very important. Cold ischemia time should be kept really short and as far as possible, not below 12 hours. If you're thinking of starting a pancreas transplant, I think it's important to train more than 1 person and have a little bit of redundancy so that 1 person doesn't take all the burden of this fairly demanding surgery. And meticulous retrieval and bed surgery is of vital importance. I feel that pancreas transplant is feasible in a public sector hospital like ours, and also, of course, in the private sector. It's the need of the hour in the country, and I think more centers need to be doing it. And over the last decade, we've seen increasing numbers of donors, and I think this represents an opportunity for the transplant community in India to expand pancreas transplantation. So it's a long and rocky road ahead, but I think we should all, it's something that the transplant community should take up. And I'm delighted to hand over the mic to Dr. Raman Dhanda, who I consider to be a mentor of mine in pancreas transplant, and who is both an excellent surgeon and a teacher. Thank you.
For a very nice presentation. I have only two questions for you. We know that this simultaneous pancreatic kidney transplant can be done in patients having, ESRD because of type 1 diabetes. What is your opinion about patients of chronic pancreatitis who have, they have diabetes developing up because of this and leading to ESRD. So is it are they candidates for simultaneous pancreatic kidney transplant? And
yes, they can be. Okay.
And second question is, you are advocating for pancreas after kidney transplant. So any specific reason for that rather than going simultaneous?
Yeah, there are two reasons. See, one is that in the West, in the UK and the US, about say more than 80% of all transplants that are done are from deceased donors. And it's the opposite situation here, where 80 to 80 or maybe 90% of transplants are from living donors, and most patients are able to find a living donor. So there are two reasons to do a pancreas after kidney, because we don't often have a lot of pancreases growing. The waiting time may be long. It may be a year, 2 years, 3 years. So to keep a type 1 diabetic, as I showed you in that graph, type 1 diabetics do very poorly on dialysis. If come to living donor, it's better to get them off dialysis. And then, when they're in better health, you can do a pancreas after kidney transplant whenever the pancreas is available. That's one reason. The second thing is that by denying them, by not taking that living donor kidney, you're actually reducing one organ from the donor pool. So if you take a living a kidney from a relative of a type 1 diabetic, you're saving one cadaveric organ which could go to another recipient. So I think these are the reasons, possibly, that a PAK is the way to go in India.
Thank you.
And as for your first question, so people with pancreatic insufficiency due to surgical or other causes do make a very small subset of recipients for pancreas transplant. But if the pancreas is destroyed and they're diabetic because they're not producing insulin and C-peptide levels are low, they're almost a type 1 diabetic, and they are candidates. And the other thing I've not touched upon is pancreas transplant in type 2 diabetics, which is controversial. Some centers do it, although I think the benefit is less marked than for a type 1 diabetic.
Thank you so much, Dr. Jamal. Thank you so much. Now we move to our other presentation, which is to be done by Dr. Raman Dhanda, who is a consultant transplant surgeon at the Department of Renal and Pancreas Transplants, Manchester Royal Infirmary. He is alumnus of IGMC Shimla and PGI Chandigarh. He has done his fellowship in pancreatic transplant from Oxford Transplant Centre, and he is clinical lead of Manchester Pancreas Transplant Program. His key areas are innovative technique in pancreas transplant, enhanced recovery program in pancreas transplant recipients, and facilitating pancreatic transplant program in India. Over to you, Dr. Raman.
Dr. Vipin, can you see my presentation?
I can't see your presentation. I can see you.
I don't know what has happened.
Share screen. Share screen option.
Yeah, I have shared the screen, but I can't. Suddenly, that presentation has disappeared. Oh my God. I'm really sorry about it. I don't know what has happened to the... It has just disappeared from this sharing. Can you see it now?
Yeah.
Can you see it?
Yeah, we can see it with very small.
You have to
Yeah.
maximize.
Raman, make it a slideshow here.
Yeah, that's what I now.
Yes. Now we can see.
All right. Okay, Vipin, thank you, you and Jamal and AIG Hospitals for inviting me to give this talk on surgical aspects of pancreas transplantation. And I'll try my best to squeeze this entire 6-hour operation into 10 minutes, and I'll try my best. So Jamal has already touched on some of the issues revolving around pancreas transplantation. So thanks for that. I don't have to repeat those. So pancreas transplantation, like any other major surgery, is a process which starts with careful retrieval of pancreas graft, followed by very meticulous backbench preparation, and then the implantation process itself. Now, the transplant procedure, I always divide into 3 modules. With the first one being achievement of adequate access, then preparation of hemostatic retroperitoneal bed, because you have to give systemic anticoagulation to these patients to avoid or mitigate the risk of thrombosis, and then the implantation process itself. Now, there are certain prerequisites for successful pancreas transplantation. Surgery success. So you need to have the right recipient. Now, I had spoken to Jamal earlier also about these things. When you are starting early in pancreas transplantation, you need to have young recipients, less than ideally 50 years of age, who are insulin-treated diabetics with progressive secondary complications. Their BMI should ideally be in, like in Indian scenario, less than 25, 26, but we do accept patients round about BMI of 30 and below, and they should have minimal or no cardiovascular disease. Then you need to have the right donor, so it could be either DBD or DCD. 60% of our transplants in Manchester in particular are from DCD donors, and we accept donors below 60 years of age, although during the pandemic we've just been more careful and vigilant and choosing only young donors. BMI ideally less than 30, but I've done pancreas transplant from a donor of 32 BMI with a pristine pancreas. So it all depends on how the pancreas looks like rather than going by the numbers. But ideally, BMI of less than 26 is what you aim for. You try to minimize the cold ischemic time as low as possible. For DCD donors, we aim for less than 10 hours, whereas for DBD donors, it's less than 12 hours. Can you all hear me okay? All right. So the most important aspect of pancreas transplantation in my experience and in the experience of other pancreas transplant surgeons I've spoken to is the backbench preparation. It is the key to the successful outcome after transplantation. And I personally feel that the foundation of all the technical complications and losses after pancreas transplantation is laid at the time of backbench preparation. So it's important that we, before proceeding with the pancreas, be able to decide which is the right or the, wrong pancreas to transplant. I've devised a checklist here, which takes only about 10 minutes to assess the suitability of pancreas. It's all self-explanatory, but the most important aspect and most common thing that helps us include or exclude a pancreas for transplantation is fibrosis of the pancreas or steatosis, and establishment of an adequate collateral flow. As Jamal mentioned, pancreas doesn't have a direct pancreatic artery. It basically relies on collateral circulation from SMA as well as the splenic artery. So some basic essentials of backbench preparation is, this is how we set up the setup for backbench. As you can see, a steel tray sits right in the middle of the ice to avoid direct contact of ice with the pancreas. and ensure that the pancreas graft is immersed in UW solution at all times. Always keep the pancreas in an anatomical position. If you have to inspect the the posterior surface of the pancreas, never try to twist the organ. Always log roll it, as you do for ATLS for the patients, and never try to twist or tort the organ, because that can predispose to pancreatitis afterwards. And the most important factor is try not to touch the pancreas parenchyma at all. So, practice this no-touch technique. This is basically the anatomy of the pancreas graft when it's received along with the mesocolon attached to it, the C-loop of the duodenum, the jejunum, and the spleen. So always work through a methodical sequence of steps and have a practice which is unique to you, so that you keep on doing the same thing without missing some important steps in pancreas benching. So we start with dissection of the borders. First the inferior border, then the superior border, then we do the splenectomy. Then we go on to the mesenteric root to reinforce it. Then work the duodenal loop to the right size for transplantation. Follow this by removal of the ganglion around the around the SMA. Then we dissect the portal vein, reconstruct the white graft, follow it by checking for collateral circulation and any leaks which might be missed at the time of reperfusion. So try to deal with them as much as possible at the backbench. And then finally, once we are happy with the collateral circulation, we transfix the gastroduodenal artery and transfix the CBD, distal end of CBD as well, to avoid any leakage of juices, duodenal juices, into the peritoneal cavity in case the CBD is not competent. So as I said, we start with the borders first. Here you can see we're not touching the pancreas at all. We are applying some Spencer Wells artery forceps to fan out the mesocolon and any omental tissue. And we use this thyroid ligature device to do the dissection and seal all the tissue around the pancreas. It works very well, seals very minute minute vessels, and it basically expedites the process of implantation. At the lower border, you'll encounter the inferior mesenteric vein, which needs to be doubly ligated as close to the pancreas as possible. Towards the second part of the duodenum, you may get proximal stumps of middle colic vessels, which need to be ligated separately. And when you dissect the upper border, you just ensure that there is no dissection between the splenic artery and the pancreas borders. So you always stay outside the tortuosity of the splenic artery to avoid any damage to the vessels supplying the pancreas parenchyma. The next step is splenic hilar dissection or splenectomy. You individually dissect the renal, the splenic artery and the veins, and transfix them, doubly ligate them with any suture, what you like, but do transfix them with non-absorbable suture. And once the spleen is out, you can use the long lengths of the suture to be held in a artery forceps, and it serves as a neo handle for you to use when you are about to reimplant the pancreas. So you don't touch the pancreas parenchyma at all. You hold the pancreas from duodenal end at one end and the Spencer Wells from the other. After you've done this splenectomy, you then carefully dissect the root of the mesentery. Ensure you are just 1 to 2 centimeter above the the surface of the pancreas, and then stay as close to the suture line as possible. I use a trioprolin in running technique to go all the way to the other end and come back, and then keep on tightening it in between, so as to afford a purse string effect on the root, because it contains the distal ends of the mesenteric vessels. After this, you go on to prepare the duodenum. The D2 is normally quite short, but then make sure that you're not using any pylorus or you don't have any ulcer sitting in the stump of the duodenum. So dissect up to the point where it's just easy with that areolar tissue, that fine adhesions peeling off from the pancreas. You stop there, and you do the same with the jejunal end. We use about 8 to 10 centimeters of the duodenum, depending on the size of the duodenal head, if we are doing enteric anastomosis. For bladder anastomosis, you need much shorter part of the duodenum, about 5 to 6 centimeter. Place the GI stapler obliquely so that you have vascularity maintained towards the apical part of the duodenum, and ensure that just close to the pancreas, you leave at least a centimeter of the duodenum that can be safely inverted, because that's corners are the most important areas where the leakage can take place from, and you want to be 100% sure that that end of the juxta pancreatic end of the duodenum is very well inverted. You can use either 3O proline or PDS. It's entirely your wish. Where you want to do it continuous or interrupted, again, it's entirely your wish. It doesn't make any difference as long as it serves the purpose you're doing it for. Then the next step, once we have done this, is vascular dissection and reconstruction. We first do portal vein dissection. As you can see, the portal vein by nature lies in a nice crater. So as long as the unstretched length of the portal vein is just about a centimeter above the crater, you should be happy to just transplant it. You don't want a very long vein, because if the vein is very long, the extrinsic pressure on it can predispose to thrombosis. So the nature has given us a very nice crater which serves like a tortoise shell around the portal vein, and try to use just 1 centimeter maximum length of the portal vein to do the anastomosis onto the IVC. And this is how it's done. We use proline sutures to hold the vein ends, and then carefully dissect it around without holding the intima at all. Once you have dealt with the portal vein, you do the portal ganglionectomy, SMA ganglionectomy. Now, there is a very tight constricting ganglion around the SMA, and once the pancreas reperfuses, almost 100% of the pancreas undergoes some degree of reperfusion pancreatitis, and this tissue swells up afterwards. This can actually cause a constricting effect on the SMA. So always try to carefully dissect this, making sure you don't damage the inferior pancreatic duodenal artery or any other tributary, any other branch in the process. So once you've done this, you divide the circumferential ganglionic tissue into longitudinal columns so that it no longer exerts a constricting effect, and then you seal the end with ligature. Next comes the Y-graft reconstruction. The most common Y-graft we use is from the donor common iliac vessels, but you can use brachiocephalic trunk, you can use common carotid artery trunk. So the most important part here is to ensure that you first of all carefully dissect all the periadventitial tissue around the vessels, and particularly at the aortic this common iliac bifurcation, you sometimes have a vasa vasorum, which, if not carefully retrieved, can cause a tear in this area, and I've seen up to 1 centimeter hole in the bifurcation of the iliac artery. If you miss this, you're going to be in big disaster after reperfusion, because you'll have no way to control it. So it's always good to make sure that there is no bleeding from there. Normally, the external iliac artery goes on to the SMA, and then the internal iliac artery, because of its caliber, smaller caliber, goes on to the splenic artery. I tend to do splenic artery anastomosis first, and then going on to the SMA to make sure that the curvature sits rightly at the time of implantation. So for the anastomosis, again, it's entirely your technique you're familiar with or comfortable with. But I use double quadrant technique for SMA anastomosis with 5-oprolin and internal iliac artery with 6-oprolin. Once you have completed the anastomosis, then it's time to check for the leaks. So you sequentially occlude the external iliac artery and internal iliac artery on the white graft to make sure that there are no bleeders towards the head or the tail end. The main area you have to be particularly careful about is the peri-SMA area where you have taken the ganglion from. Once you have implanted the pancreas, that becomes a very inaccessible dependent part of the pancreas, and ensuring hemostasis there can be very difficult. And that is the area where most of the lymph leaks and collections take place and bleedings take place. So make sure that you have sealed that area and you are confident before you go ahead with the anastomosis. So this is particularly for you, Jamal. There's a very interesting case last week I had. What do you think about the Y graft we have obtained from a 39-year-old donor? So the pancreas was beautiful, the kidney was good, and this is what we had as a graft. What do you think?
Well, that looks like a hematoma more than anything else, but I can't be sure.
So what do you think? What might have happened in the retrieval? It's multiple hematomas.
Multiple? There's been a puncture and there's sort of a sub-adventitial hematoma, which is about as far as I can make out on my screen.
Yeah,
but,
so we were worried that the way this graft looked, it was very badly retrieved vessels with intimal dissection, throughout the common iliac artery and extending into the internal and external artery. So we had a look at the kidney, and the kidney looked the same. There you can see some hematomas there, but they were more like bruises rather than hematomas, and they weren't compromising the lumen of the artery. Now, considering the quality of the graft, both the kidney and pancreas, I went ahead with reconstruction by using healthy part of the external iliac artery to go on to the SMA, and to use the healthy part of the internal iliac segment onto the splenic artery. And then I anastomosed the end of the internal iliac artery graft onto the SMA to reconstruct a new graft. So the patient underwent transplant. She went home day 6 with dual graft function. She is very well with normal kidney and graft function. So as far as the operation is concerned, we go through a midline laparotomy. In the past, people were going through bilateral groin, Rutherford Morrison's incisions as we go for kidney transplants, but they are not obsolete now, and we no longer use them because of the complications associated, particularly with the pancreas transplantation in the retroperitoneal area. When we go inside, we don't compromise on anything short of a formal Catal-Brash maneuver. We slightly modify it. We start it from the cecal end, go up the ascending colon and dissect in the plane between the colon and the Gerota's fascia on that side. That's the natural avascular plane you stick to. Some of these patients, when they are on peritoneal dialysis, they have a lot of scarring around the ileocecal region. So I slightly modified the technique in those patients by going just above the gonadal plane of gonadal vessels down to the psoas fascia, and then working diagonally towards the DJ flexure. Once you have done that, then you can very well get the hepatic flexure mobilized, and the entire viscera can be moved from the right side onto the left side of the IVC. And that's how it should look when you've completed the dissection in the right plane. And this is the picture from the retroperitoneum, where you can see the native kidney there, the ureter kept laterally, the IVC fully dissected, and the common iliac artery is the artery we use for pancreas inflow. I tend to hitch the bladder outside the peritoneal cavity, and it just gives added space in the pelvis for me to place the tail of the pancreas there after we have implanted and before we close. So the most common systemic drainage is portal venous to IVC, and that's the first anastomosis we do. Again, tend to do it as double quadrant, but if the vein is short, we just do it continuously as Dr. Kishore described with the robotic technique, so we can just sew it from inside. Some of this very few centers in the world now do portal venous to SMVO portal vein anastomosis. It's more or less obsolete now because it's very complex. It was basically done to deem it to be more physiological than the systemic drainage, but the literature evidence doesn't go in favor of portal venous anastomosis more than what we do currently with this with the systemic venous reconstruction, and that's what is the usual practice. Arterial inflow is through a Y graft via common iliac artery or aorta. Again, we tend not to go to the aorta. We use common iliac artery without fail, and we've never used dual artery inflow from aorta at all. If at all dual artery inflow is required, then we prefer to go on iliacs because we tend to put the kidney contralateral to the side of the pancreas. Next comes the exocrine drainage. So in order to be as physiological as possible, and some of the patients, particularly as Dr. Bipin asked about patients with pancreas exocrine insufficiency, we try to do the anastomosis as high in the bowel as possible. So I tend to do duodenojejunal anastomosis 50 to 80 centimeter from the DJ flexure. So once we have implanted the pancreas, I create a mesocolic window through the right mesocolon, pull the duodenum through that window into the anticolic compartment, and use the loop of the jejunum to anastomose to the side of the duodenum, just about 1 centimeter wide anastomosis, into side to side with 2 layers of PDS suture. 3-0 PDS is what we use. Now again, bladder drainage again has gone obsolete. We rarely use it unless there is a specific reason for not being able to use the bowel, but there is never one. And this was done in the past to facilitate immunological monitoring. Now we have far better parameters. Even in patients who have bladder drainage, about 70% ultimately do require bowel conversion. And so in our practice in last 6 years, we've only done one bladder drained pancreas transplant. Once the pancreas is in, we place the kidney contralaterally. Most of the time we just put it intraperitoneal, and as Dr. Kishore was also mentioning, and there is always a worry that the kidney might twist or tort, but in our practice we've never seen that. In fact, the kidney sits very nicely just lateral to the sigmoid colon, which usually is heavier in these patients because of autonomic bowel dysfunction, chronic constipation, and kidney never gets an opportunity really to twist into or tort into the peritoneal cavity. But of late, I've started, doing an extraperitoneal pouch from through intraperitoneally, as Dr. Kishore demonstrated. And this is just to facilitate easy biopsy, just to give more confidence to our nephrologists post-operatively to biopsy the kidney, because they are quite nervous about biopsying a kidney which is placed intraperitoneally. Finally, we do a washout, drainage, and closure. I use 3 drains, Robinson Wallace drains, non-suction ones. So 1 on the kidney side, 2 on the right side of the abdominal cavity. 1 sits subhepatically, because for initial 2-3 days when the patients are in intensive care, they are not mobilizing well. So the most fluid actually collects in the subhepatic pouch. So I leave a drain there, and that's the first drain I remove when the patients start mobilizing. The second drain sits alongside the pancreas into the pelvis, and it's basically removed once the pancreas enzymes in the drain is normal, irrespective of what the volume is. Post-operatively, we give them Campath, and we use a steroid-free regimen with tacrolimus and mycophenolate mofetil. On the ITU, they receive routine cardiac output monitoring. I start feeding my patients now from day 1 after transplant, and it's been almost 26 patients I've subjected to enhanced recovery, and they've done very well. With the earliest patient I've sent home is day 6 after simultaneous kidney pancreas transplant. Our overall hospital stay from average 3 weeks has gone down to 7 to 10 days now, with introduction of this enhanced recovery program. And one thing I just wanted to, I don't know whether Dr. Pandey is still here. One thing we try not to use in pancreas transplant patients is too much of crystalloids, because that causes pancreas edema and more chances of pancreatitis. We tend to use colloids. So 4.5% human albumin solution is what we tend to use for for intraoperative rehydration. But post-operatively, I tend to get them off fluids as soon as possible. We give them heparin infusion for about 48 hours, but this is something which we are about to change very soon. We do get dual graft primary function in majority, and as I said, they are transferred to the ward in 3 to 5 days and home by 7 to 10 days after pancreas transplantation. Thank you.
Dr. Raman, I have 2 quick questions. I saw in your presentation that you are very skeptical about touching the pancreas.
Yeah.
So, do you advocate during harvesting a person who is exceptionally trained for retrieving pancreas, rather than a surgeon who is, going for multi-organ harvesting? Second question.
Yeah, I'm sure the people who are the surgeons who are trained in multi-organ transplantation and multi-organ retrieval, they have to have the knowledge that pancreas is one organ which we shouldn't be manually handling too much, which is why during retrieval it's advocated that we use spleen as the handle, and just gently with the closed fingers gently spread the this retroperitoneal tissue of the spleen, rather than, and preferably use even sharp dissection to avoid directly touching the pancreas. One other thing apart from touching the pancreas is that we advocate portal venous cooling, reperfusion, rather than using SMV or IMV for that, because that can actually cause a lot of hyperperfusion of the pancreas and subsequent incidence of pancreatitis. So yes, they also have to be careful that this no-touch technique has to be advocated not only during retrieval, but even whilst benching the organ, whilst packing the organs and sending them over to the transplant center. So ideally, and definitely it works quite well in Indian scenario, people who are doing pancreas transplant probably should be, should have somebody specifically trained for them to retrieve the pancreas. I won't say that somebody like Jamal, who has been working really very hard to go there, retrieve the organ, come back, and then do the backbenching and do the implantation itself as well. It's a big ask. but definitely pancreas requires a lot of respect, and that determines the outcome of pancreas transplantation afterwards.
The second question is, after this pancreas after kidney transplant, suppose the kidney has been placed in the right iliac fossa, then where do you put the graft?
So that's quite interesting, and then because we normally serve as a catchment center for different centers which do have their local kidney transplant centers, but for pancreas transplantation the patient come to Manchester. We always advise them to put the kidney on the left side, because we tend to go on the right side with the pancreas transplant. But interestingly, once the kidney has been there for a while, it does tolerate reasonably well the short rewarm ischemia time whilst you are doing the pancreas transplant. Pancreas transplant takes only about as far as the anastomosis is concerned, once you have good retroperitoneal exposure, it only takes about 20 minutes to do both the anastomosis, because you have so much of space there. But if you are worried about causing concern to the kidney, all you have to do is keep the Y graft a bit longer and go to the common iliac artery on the left side. So that's the only thing.
Just a couple of questions. Excellent and comprehensive presentation, Raman, as always. So one question was, why do you do a full cattle brush all the way up to the duodenum? Because the pancreas transplant is mostly taking part in the mid and lower abdomen.
Yeah.
You don't really go up to the hepatic flexion so high. So isn't that just excessive dissection, which could lead to more bleeding in an anticoagulated patient?
I can, definitely, Jamal. It looks a bit excessive that we are doing this for pancreas transplantation. But one thing you have to keep in mind. Well, the first point is that if you do a careful cattle brush, that is meant to be, the most avascular plane you can have the dissection in. So it's never honestly been an issue in terms of bleeding. The most important thing after pancreas, as I said, 100% of the pancreas undergoes some degree of reperfusion pancreatitis. There's always swelling of the pancreas afterwards. Now, if you are keeping the tissue dissection of the viscera very tight around the pancreas, once the operation is over, all that elasticity of the tissue is going to come back and possibly compress on the pancreas and not let it breathe as much as easily as it should. The whole idea of doing cattle brush is that you have taken that possibility of elasticity away. You have pancreas sitting in a very comfortable environment, sitting without any kink, without any torsion, and without any possibility of tissue coming back onto the pancreas and causing any extrinsic compression. So that's what we have done, and we don't know what exactly. There are multiple factors which determine the outcome. But before I joined Manchester, it wasn't the routine. So this cattle brush maneuver was something I learned, picked up from Oxford, and then started practicing in Manchester. And you won't believe our pancreatitis rates and re-exploration rates with the pancreas transplants just nosedived. Our pancreatitis rate was almost about 30%, and we are down to 7%. And that too, if you look at severe pancreatitis, in last 5 years of more than 170 transplants, we've only had one severe pancreatitis. Otherwise, it used to be sort of a norm that you do pancreas transplant, and 4th, 5th day, we used to take the patients back to theater for washouts. And ever since we started using this cattle brush maneuver and doing that dissection there, it just disappeared, that high incidence of pancreatitis. Now, our graft loss rate was almost about 17 to 18%. And for last 5 years, we've achieved a graft loss rate of less than 2.3%. And that's Two, with the fact that we are 8 surgeons doing the transplants now. So there's so much of variability, but despite that, I think the technique of cattle brush, open intraperitoneal placement, keeping the cold ischemic time to less than 12 hours, and using a uniform technique throughout has worked wonders in our program.
Excellent results.
Thank you so much, Dr. Raman.
One more brief.
Yeah.
Over time, can I have one more question, or should I ask?
Yeah, please ask. Please ask.
Raman, one thing that I've found with our diabetic patients is that they seem to have a lot of enteropathy. Typically very large, sort of flabby stomachs, and a lot of them have, colons which are absolutely loaded with fecal matter, and I find, a late return of bowel function. So is that something you've ever faced in the past? And now, of course, you have very quick recoveries, but is that something you've faced in the past, and do you have any sort of suggestion how to minimize problems?
Yeah, no, Jamal, it's quite a common problem here as well. So about 30% of our patients, they do suffer from constipating type of autonomic bowel dysfunction. So they tend not to, open bowels for days after, and it's usually quite a difficult thing for us to manage, and gives us sleepless nights, particularly with the anastomosis high up in the jejunum. And when you have already started feeding them, and then you realize 4 to 5 days afterwards they've stopped suddenly passing any flatus, or they're not moved their bowels for days after. So one thing which I've tried different things, but one thing which seems to be working in my own practice is, after transplant, I give them regular daily enemas for 3 to 4 days, irrespective of whether they're bowels or not. And second thing is that I tend to start them on prokinetic agents quite early after transplant. So I tend to use metoclopramide and buscopan being the first first choice, and then add metoclopramide. And that seems to, I won't say that it has completely taken off all the issues, but it has definitely reduced the incidence quite massively. And that is one reason why the patients have been able to go home earlier. In my experience, one thing which I've learned is, if you can facilitate bowel function and facilitate kidney function early, then pancreas transplant becomes a walk in the garden. They do so well afterwards. But ileus and delayed graft function of the kidney, they definitely create problems, and that's all again down to there's fluid overload and edema of the pancreas. And if the retroperitoneal lymphatic tissue is not being retroperitoneal lymph doesn't get a chance to recirculate because of the visceral edema, all that leads to collections, then sepsis, and worst outcome for the patients. So I think if you can move the bowel early and the kidney functions straight away, then you can almost guarantee success for your pancreas transplant.
Do you think there's anything we can do in waitlisted patients to improve their bowel function?
I don't think so. There is
anything or something
we can do. I mean, the only thing is, as part of, as Dr. Sunil said, we also very strictly follow the enhanced recovery program. In fact, no other center in the UK has actually has experience in enhanced recovery. So I was the first one to start in Manchester, and then we are trying to get other centers involved and get a national database on it, how the improvement has happened in pancreas transplantation with enhanced recovery. But as part of rehabilitation, and when we assess the patients, the only thing we can do, and we advise them to, is to maintain on regular laxatives if that is something which they are dependent on. Because I don't think so there is anything. Well, gastroparesis can definitely be improved. We do have patients come to us on gastric pacemakers, but for colonic dysfunction, I don't think so there is anything at the moment which can help us. The only thing it helps us, as I said, is to help place the kidney extraperitoneally and doesn't twist, because a loaded bowel, sits around the kidney very nicely without causing any torsion or medial rotation. That's the only thing.
Thank you
Thank
so
you.
much, Dr. Raman.
Thank
Now
you very
we'll
much for
move to our next lecture, which is on simultaneous liver and kidney transplant. And to speak on this, we have Dr. Balchandran Menon with us, who is Director of Liver Transplant at AIG Hospitals. He has been trained in vascular surgery from Sri Chitra and in GI from SGPGI. He has done his fellowship in liver transplant from Samsung Hospital, Seoul and Sir Gangaram Hospital, New Delhi. He was Director of Liver Transplant at Yashoda Hospital and has performed and has been part of more than 2000 liver transplants till now. Over to you, Dr. Balchandran.
Good evening, everyone. Thank you, Dr. Bipin Paul, for giving me this opportunity. So, as the last man, I'm going to talk on simultaneous simultaneous liver kidney transplant, not particularly living donor. So, you will all agree that both liver transplant and kidney transplant are quite established. They may be complex surgeries, but they are quite well established with excellent results. End-stage liver disease is often associated with renal dysfunction. It might, but not always, resolve after a liver transplant. Simultaneous liver kidney transplant is surgically and medically a complex procedure. It's uncommon, and probably different criteria should apply for SLKT in deceased donor and for LDLT, especially in the eastern countries and in India. If you look at the impact of renal dysfunction, roughly about a third of liver patients, the more sicker the patient, more is the incidence of renal dysfunction. And the incidence of renal dysfunction increases the bacterial and fungal infections, post-op renal failure, and has a big bearing on hospital mortality. When you do the liver and kidney transplant together, the microchimerism and tolerance and the large size of the liver allograft improves the kidney transplant and decreases the kidney transplant rejection rates, especially the early rejection rates. If you look at the incidence of SLKT over the last 15-20 years, there has been a gradual increase, especially it started in 2007 when criteria started coming in. If you look at the indications for SLKT, you can actually club it into two different headings: kidney pulling liver or liver pulling kidney. In kidney pulling liver, it's actually the kidney is bad, but liver is not that bad. So you got end-stage renal disease with cirrhosis, which was actually detected during workup, actually the cirrhosis is not that bad. It could be end-stage renal disease with metabolic diseases like hyperoxaluria or polycystic disease. Liver pulling kidney, these patients are more sicker. It's the bad liver which has actually caused kidney disease, or it might be even an end-stage liver disease with a known chronic kidney disease. More commonly what we get in this group is end-stage liver disease with acute kidney injury. So all the controversies actually happen in this last variety, that is end-stage liver disease with acute kidney injury. Kidney pulling liver, these are very good patients. You can give very good results, especially the end-stage renal disease, where you actually have a little bit of cirrhosis. Here the evidence of cirrhosis might be just ascites or varices on endoscopy. And when you do the hepatic venous pressure gradient, if you find it more than 10, doing a kidney transplant alone would be risky. So it's always combined with a simultaneous liver kidney transplant. Now what is more dicey is liver pulling kidney. In this also indications are easy. when there is cirrhosis with established CKD. The problem comes in when there is cirrhosis with acute kidney injury. Criteria are different. What probably applies in West may not apply to Indian scenario. In West, the emphasis is mostly to actually prevent kidney, since like in US, there are at any point of time about 100,000 patients waiting for transplant. So idea is not to waste the kidneys. So some of these patients with AKI may actually recover even if you don't do a kidney transplant. If you just do a liver alone, some of them may recover. But in Indian scenario, it's different. The patients are more sicker. They have had multiple episodes of AKI. Each episode of AKI actually keeps on damaging the kidney. Always there is overlying sepsis. Most important, they are having family donors. So there is no competition, unlike for a cadaveric transplant, and there is always an emotional angle to LDLT. So probably we should have more relaxed criteria. So if you look at cirrhosis with AKI, 2/3 of them are pre-renal. Of this, 1/3 are hepatorenal, which do not respond to fluids, and 1/3 of them have intrarenal issues. So about 20% of this subgroup, that is cirrhosis with AKI, actually have pre-renal disease, which can be diagnosed as HRS. So HRS, AKI, both are very, there's a lot of overlap and diagnosis can be difficult. What is more important to realize is multiple episodes of HRS. With each episode, there is increasing structural damage and the kidney may not recover after a transplant. So this is what we find here. So I would say that we are hardly able to do 1/5 of the patients with HRS or with AKI. Maybe I would, over these last 5-6 years, I've hardly done about 8-9 patients. I would have liked to do 40-50, but finally convincing the nephrologist to actually go in for a SLKT has been difficult. Because there are a lot of gray areas where AKI and HRS actually overlap. Sepsis is always a compounding factor, especially in India. The gold standard, of course, is kidney biopsy, but with a bad liver, doing kidney biopsy is always dangerous. And over these years, hardly seen more than 2-3 kidney biopsies been done, and they have actually not been very helpful. This is a very common table which you will come across in most of the textbooks. If you look at this hepatorenal syndrome and intrarenal pathology, you will see that one important thing is in HRS you will get a bland urine with no sediment, but in intrarenal pathology you get CAS, hematuria, proteinuria. The urinary sodium is more than 40 there, but in HRS it's less than 20. If you look at the response to vasoconstrictors, there is reversal in about 60 to 70%. But with multiple episodes of HRS, this response to vasoconstrictors is actually lost. Lot of guidelines have been coming over past few years. The latest one, that is in 2017, where AKI has been diagnosed as, AKI which comes into guideline, fitness for transplant, is when dialysis has been going on for more than 6 weeks. GFR is less than or equal to 25 for more than 6 weeks, documented every 7th day, and a combination of these two criteria. So it's very difficult to meet these criteria in an Indian patient. When creatinine, when a patient with cirrhosis, advanced cirrhosis, goes in for dialysis, they barely last for 6 weeks here. And if you look at the rifle criteria, patient has to be in stage 3, that is failure, for 6 weeks which is a pretty long period for most of the Indian patients, and maintaining them in ICU and maintaining their kidney status and keeping them alive for that long is a very difficult point. So points to ponder is, when you do LT alone, the risk of renal recovery and higher mortality, whether it's acceptable. Post LT, if you wait, and if you are able to do a transplant without kidney transplant, and when you put them in kidney transplant wait list later on, they have significantly higher mortality even in Western situation. In India, it might be very, very difficult. So there are some criteria for DDLT, but still we don't have any guidelines in a LDLT scenario where actually probably different criteria should apply. So if you look at whatever I have said over the last 5 minutes, kidney pulling liver criteria are good. You can easily stage them for transplant. But liver pulling kidney, the criteria what is available right now are very strict. It's very difficult to actually push them towards SLKT. Patients are more sicker, more septic. And if you look at the results of SLKT, patients with cirrhosis, bad cirrhosis, who undergo SLKT, they have a 5-year survival, which is pretty good, 70%. With metabolic diseases, they are the easiest of the subgroup. You can get easily 90% survival. So what probably applies is, when you have creatinine, which is more than say 1.6, 1.7, or say, I would put it as 1.8, and if that persists for about 2-3 months, it's very difficult to push in a patient for an LDLT. The reason is the graft is small, patients are more sick. But the same patient for DDLT might be okay because you got a big graft, especially if the quality of graft is well, there is a much better chance that the patient will get time for kidney to recover. GFR less than 30 for 3 months, yes, and definitely dialysis dependence for greater than 6 weeks can be a criteria. So what we follow is, we do a renal protocol, we keep the CRRT ready, we see to it that we don't cross clamp the IVC. All anastomosis are done with side clamps, hepatectomy, and meanwhile, while benching is going on, we actually do a shunt so that it's on flow, and once it's done, once everything is ready, we go ahead with the implantation. And at the time the bile duct is being done, the kidney harvest is started. And we have not been doing induction therapy, only methylpred is being used. The reason is, most of our patients are pretty septic and they don't tolerate they just tolerate methylpred during an hepatic phase. So this is a patient, the last patient which we did, the liver implantation has been done, and this is the final stages following kidney. The post-op protocol is more like kidney transplant. Urine output goal is kept at about 200 to 300 ml per hour, and replacement with 100% normal saline up to 500 ml per hour might be required. We do daily Dopplers, especially for the liver. Immunosuppression is more like that of a liver transplant patient. Initially 3 drugs, later they come down, and incidence of rejection, as I was pointing out, is much lower. Over the last 5 years, 5.5 years or so, we have done only about 8 patients. The mean age was 42. If you see this, the bilirubin values were not very high. Creatinine was roughly about 4. 3 of them had ascites, encephalopathy was, in fact 3 of them had pretty bad livers. If you see the split up, we had 3 patients with hyperoxaluria, and the remaining were patients with primary liver disease. It was pretty easy to convince the nephrologist in the patient with interstitial nephritis with primary biliary cirrhosis and diabetic, and another patient with diabetic nephropathy. Convincing them in the other 3 patients were pretty difficult. These were the oxalate, pre-op oxalate levels of patients with hyperoxaluria. We had subjected them to multiple dialysis before taking them for transplant. We did left lobes in 2. The mean graft weight was about 740 grams and the graft recipient weight ratio was about 1.28%. Post-op, we lost 1 patient primarily to sepsis. Perioperatively, CRRT was required in 1 patient, and most of the other patients had more or less a very non-specific course. Surgical complications, there were hardly any major complications in these patients. The patient who expired actually basically died of sepsis. He needed re-expiration twice and died of progressive septicemia and multi-organ failure. The hospital stay was roughly about 18 days. All the 7 who are alive are doing well with a follow-up period of about 25 months. And the present mean creatinine is about 1.07. This is our last patient who actually had active. So I was saying that there is good patient liver and kidney graft survival is seen when you are doing a simultaneous liver and kidney transplant. And in a living donor scenario, especially the Indian one, we should look into the criteria, and probably the Western criteria may not apply. With this, I would thank you again. There may be a lot of controversies and questions. I would be happy to answer.
Quite convincing way, so I appreciate that, and if there are questions I will take on.
Yeah, so I have one question for Dr. Bala.
Please go ahead.
Yeah, please.
Yeah, because that was a good presentation and I enjoyed watching it. So one, if you have a patient who's on a deceased donor list for liver transplant, who also needs a kidney, according to your allotment criteria in your state, would the kidney follow the other organ, the liver?
I didn't get your question actually.
Would you get both organs from the same deceased donor?
No, well, see, actually getting a kidney in India is difficult. So what we tell them is, you get a live kidney donor and keep the patient on cadaveric transplant list if they don't have 2 donors. Is that what you meant? We do.
What I meant was, suppose you have a patient who needs a liver and a kidney, who needs an SKLT, but who doesn't have a living donor. According to allotment rules there, once they get a liver, would they also get a kidney?
Yes, there is priority when they require both the organs. So they are actually prioritized and they get both the organs together. But the criteria are so strict.
That is actually very relevant.
Criteria is being followed here. So very few of them actually are able to get a SLKT cadaveric.
Right. I mean, this is actually very relevant when it comes to simultaneous pancreas kidney transplant. I mean, we're fortunate in our state that the rules are such that for a pancreas recipient, the kidney follows the other organ. And I believe that this was the case in Tamil Nadu until a few years ago when the rules were changed. That led to a marked decline in the number of simultaneous pancreas kidney transplants that were done. So I just wondered what the situation was for SKLT.
Actually, SKLT is, I mean, it's prioritized in all states, but the criteria are too
Right.
strict. So that's why finding a,
Yeah.
I mean, for them to get a cadaveric SKLT is very difficult. So what we tell them is, you either get a, I mean, best is if you can get a live kidney donor, then things become
Right.
easier.
So, one more small technical question that may sound quite funny. You show the abdomen of a patient after SKLT, and it seems that the right side of the abdomen with the subcostal incision and the Rutherford-Morrison incision. Is there any concern about the blood supply to the abdominal wall on the right side? And would you do something like preserving the inferior epigastric artery while making the kidney bed to maximize that blood supply? Have you ever had necrosis of the flaps there?
Well, the kidney here is in India is done only by the urologist. So once we start
Yeah,
doing the bile diet, we give them a ring. So then at that point they start doing their work. So I think they are the best people to answer this.
Yeah. Right.
So if there are no other questions, I think we come to the end of the program, and I thank all the speakers for participating in the symposia and making it successful. And I also thank AIG Hospitals for giving me opportunity to host the program. So thank you so much once again. Good night. Shubhratri, Shabha Khair.